Welcome back to taking charge of my cancer podcast. And I have a very exciting guest today, Dr. Rebecca Knackstead. She is a board certified plastic surgeon specializing in implant-based and microsurgical breast reconstruction. She is currently an assistant professor in plastic and reconstructive surgery at Duke University. She completed her MD and PhD at the Medical University of South Carolina, where her PhD thesis focused on vitamin D and inflammation. She pursued an integrated plastic surgeon resident and microsurgery fellowship at the Cleveland Clinic, during which she also became certified in functional medicine. Her research interests are pre-rehabilitation for breast cancer, particularly for women undergoing neoadjuvant chemotherapy. She has published over 90 peer-reviewed studies and has been giving numerous local and national lectures on her research. So, Dr. Nassad, it's a pleasure to have you here with me today.
Yeah, thank you so much for inviting me.
Absolutely. So, can you share with what was your journey into plastic surgery and what inspired you to also pursue functional medicine?
Yeah, I interestingly always had a really strong vasovagal response to blood as a child and as a teenager. So I was very fearful going into med school that I was going to be that medical student that passes out in surgery. And so when it came time for my surgery selective, I chose plastic surgery because I thought it has to be the least bloody surgery, right? I was wrong. Plastic surgery can be quite bloody. But during my selective, I found out that one, I didn't pass out, which was a huge positive. But two, I really liked the scope of practice, and I really at that time fell in love with breast reconstruction. I really liked the idea of being able to restore something that was taken away from these women for nothing that they did wrong, and being able to restore femininity and confidence. And I really fell in love with plastic surgery and breast reconstruction very early. I decided to do the functional medicine because when I was a resident, I had this history of nutrition and my PhD and research, and I've always been very interested in nutrition. Kind of completely forgot about it during residency. But then I would see in clinic patients routinely asking surgeons, what can I do to prepare for surgery? What can I do before surgery or after surgery? What should I eat? And the answer was always some vague, I don't know, be healthy, eat healthy, which means nothing to the surgeon or the patient. So, just to give myself a better background in nutrition and just to lend more credibility to what I wanted to be able to talk to my patients about, I decided to become certified in functional medicine. And that really taught me that preparing a patient for surgery was more than nutrition. It really was looking at a patient holistically and things that I hadn't thought about before. Things like stress and anxiety and sleep and who your social support is before and after surgery. So I'm really glad that I chose to do that training and I gained so much more from it than what I thought I was going to get going into the training.
So, how do you define that intersection between surgery and functional medicine in your practice, right? Because I'm surrounded about traditional medicine. So, how do you kind of start to kind of like bring in this piece of the element or piece of the puzzle to your colleagues, or how do you manage that where you're at now?
Yeah, it's hard because, as you know, amongst medical doctors, especially surgeons, we love data. We love papers and studies. And a lot of the things that I talk to patients about are on the fluffier side. Things like sleep and stress and yoga. There maybe aren't great randomized controlled trials looking at yoga. So it's kind of hard to convince surgeons to care. So, first, I started by integrating it into my own practice. And I saw firsthand that the patients that really embraced this idea of rehabilitation just did better. And when I saw that, I started to talk to some of my colleagues, and my colleagues all know how passionate I am about that topic. But for me, what was frustrating is that as a surgeon, I will only directly impact the patients that I do surgery on. So I needed a way to get the information to more patients.
Yeah.
And that's when I started appearing on podcasts. I'm writing a book that's geared at rehabilitation for breast cancer patients. I've given a lot of national lectures. And just through that, it's educating patients, but also providers, surgeons, functional medicine providers, and just really reintroducing this idea of prehabilitation back into the surgical field.
That's so great. We do pre-rehabilitation for a lot of things, right? A lot of our orthopedics, right? We do pre-rehabilitation for total knees. We do
Hmm.
rehabilitation for ACLs, and it's just should be part of the whole thing. We see that already because we have such a great program from breast here where we see patients pre-op. So pretty
Hmm.
much I see them 2 weeks post-op and then I know what's going to happen. So you're going to have a DIP, like, maybe 3 months from now, we're going to start working on your core and we need to start to prepare you and we're going to try to decrease your body mass, body fat mass, and let's just work into all these things that you need to try to help you to recover a lot faster. And you're right, they do so much better than the ones who just really just go blindly into surgery without preparing
Yes,
themselves. So that really is a
absolutely.
big difference. Um, how do you guide patients when choosing between implants and autologous flap reconstruction?
That's a hard discussion, and that's why consultations last so long. I think that some of the big takeaway messages that I really try to emphasize with my patients that regardless of what they choose, one, reconstruction is optional. It doesn't have to be done at the time of the mastectomy. It can be done at a later date. If you choose a type of reconstruction that you don't like, you can always choose another one in the future, or you can do a hybrid approach to reconstruction. Patients feel so overwhelmed, especially if they're having a mastectomy with reconstruction. They feel so overwhelmed at that initial consultation where they've just been diagnosed with cancer. They're being told they might need radiation, might need chemo, and then they meet with me and I'm giving them this buffet list of options that they can choose from, which are all good options for them. So the main points that I drive home about implant-based or autologous is first deciding if a patient is a candidate for either. So things to think about would be smoking status, not a candidate for either if you're a smoker. But once you move beyond that, body habitus, do they have enough body tissue to be a body-based reconstruction? Do they need radiation? Are they a candidate for implant-based reconstruction because of radiation changes to their breast? And then a lot of it has to go into how many surgeries the patient wants to have.
Hmm.
Implant-based reconstruction tends to be a lot of small surgeries over the course of the patient's life, as opposed to a body-based surgery is more of a bigger surgery initially, and then maybe a small surgery later. So some of those fit in differently into different people's lifestyles. I have a lot of women in my practice that are in their 30s. They have an active career. They're busy raising their children. They were just given this breast cancer diagnosis. So maybe they would love to have a deep flap, but it's just not in the cards right now to have a 4-month recovery. So maybe doing implants is a good option for now. And then later, when life slows down a bit, maybe do a flap. So there's so many things to think about. And one of the things I ask patients is, what are your hobbies? So getting to know what muscles are important to their hobbies. If I have a patient who's an active swimmer or a golfer, I'm thinking I want to really preserve her latissimus muscles. I don't want to be doing a latissimus flap. So there's so much that goes into that discussion. And that's why I think as a patient, the most important thing is to find a plastic surgeon with whom you connect, with whom you feel comfortable asking those weird, awkward questions and having these long, thoughtful discussions. Because otherwise, you're going to sign up for a surgery that you either don't understand or isn't right for you. And then that's what leads to things like surgical regret and dissatisfaction with the appearance of your breasts.
Yeah, that's a very valid point. Do you feel that you always have to kind of look into expanders prior to going into that implant? Because sometimes when I come across these patients who come from other institutions and they wanted to have implants and they were never had a consult with plastic before, and they have a radical mastectomy, and now they're going through radiation, and it's like, this is not an option for an implants any longer because no expanders were used. So, what are your thoughts?
Right. I'm a huge fan of direct implant reconstruction, even for patients who need radiation after surgery. In fact, if a patient needs radiation, my goal is to place the implant at the time of surgery. It's a
Really?
little bit still conflicting data in our literature, and I think that either one is a good option, tissue expanders or implants. If a patient is having a skin sparing mastectomy, meaning we're removing the nipple and the areola, they might not be a good candidate for a direct implant because I'm removing some of that skin cover. So I'm not going to have as much available skin to cover an implant at the time of the mastectomy. So for those patients, a tissue expander might be a good option. But if patients are having a nipple sparing and they're happy with their size, or they're having a skin sparing and willing to go smaller, direct to implant can be a really nice option. You wake up with something that resembles a breast. Patients hate tissue expanders, they're uncomfortable. You
Yeah.
can get out of a mandatory second surgery. So I really like direct to implant, and patients, especially in the literature, shows us that patients really like direct to implant as well, but not all plastic surgeons offer it.
Yeah, that's true. We don't get to do that as often here. What are you worried about capsular like capsulitis or capsular retraction if they go into radiation with the implant or the radiation
Question.
messing up the implant?
Yeah, so I would say even 10, 15 years ago, the answer if a patient had radiation was a body-based reconstruction. That was the only option. And over the last decade or so, that thinking has kind of changed. And now it's acceptable and well reported in our literature that you can have direct implant and then radiation, or you can have a tissue expander, radiation, and then an implant. Capsular contracture is the tricky one. And some patients who have radiation, it's always going to look different than the other side. It's always going to be a little bit contracted. But for a lot of patients, it's in the realms of normalcy. It's something that's with clothes, still looks acceptable and is aesthetically pleasing. But in some women, it can be painful and distorting. And for those women, we then switch to a body-based reconstruction. So for some patients, I tell them it's worth a try. Let's see how you do after radiation. But once again, it might be something where we buy 8 or 10 years, and then when you're at a better place, you haven't just finished chemo, your kids are a little bit older, maybe we do a body-based reconstruction in the future.
Okay, that's very good to know. What roles does pre-rehabilitation or preparation play before surgery in terms of functional medicine?
When I started my practice, I really thought that nutrition was the answer to everything. It doesn't matter what else is going on in the patient's life. If I give her some targeted supplements before surgery, she's going to sail through surgery. And that was really based on the fact that as a resident, I didn't go to clinic. So I didn't get to know patients. I didn't learn all of the things that are happening in these women's lives as they are diagnosed with breast cancer and navigating chemo and radiation. And as I started my own practice and really got to know my patients, and I learned about what's going on in their family lives and how much time they're taking off work, and they're concerned about paying their bills. And I realized how much stress these women are under. It really made me realize the impact of things like stress and anxiety on surgical outcomes, how stress and anxiety impacts sleep, which impacts surgical outcomes. And so it's once again, it's looking at patients holistically. Yes, it's looking at objective things like your skin quality and your ANC and your hemoglobin, but it's also asking things like who's taking care of you after surgery? Who's going to be bringing you to your postoperative appointments? Do you have anyone to bring you to your postoperative appointments? Not only will that impact surgical outcomes, it just impacts feasibility. If you don't have anyone to drive you to your post-op appointments, you're probably going to miss your post-operative appointments. And I've seen in my own patients how that leads to, missed early complications that lead to big complications. And it's hard to navigate. So getting those patients in with our counselors early, in with our social support early, getting them resources in the community is just so important, because otherwise we're doing a surgery on them and just setting themselves up or setting them up for failure if we're not giving them those resources.
Do you ever refer for physical therapy prior to it?
Usually not prior to it. At Duke, we have the supply and demand of physical therapists is tremendous. They are so overworked. I'm sure with you too. There's just so many patients that could benefit from physical therapy and just not enough providers. So usually I just send them after physical therapy, but I have a very low threshold. Like as soon as I lift activity restrictions, if they're not bouncing back to baseline, it's immediately going to physical therapy. And it might just be for one visit just to learn some stretches and exercises to do at home, or it is a more intensive guided 6-week intervention, especially if they're having early signs of lymphedema. I want to get them in to see physical therapy as soon as possible.
Okay. Do you have any special like protocol or like after a DIP, like when do you send them for PT?
So usually I send them for PT at 6 weeks.
Okay.
And that's just because that's how long my activity restrictions are in place for. So I found it's easier to just send them when I say you can do anything your physical therapist tells you, as opposed to I tried early on to send them at about 4 weeks, and it just kind of got the waters got a little muddy. So it was just easier to do 6 weeks. And it's amazing how fast patients really do bounce back if they're invested in their recovery and really do that physical therapy.
Do you keep them a restriction to 90 degrees at all on the first
For
four
for
weeks?
6 weeks.
For 6 weeks, you keep
Yeah,
them
after a deep for six
for a
weeks. Yeah.
day. Okay. Okay. No for implants, right?
It's less for implants. Usually I do about 4 weeks, but my main concern with implants is early movement can lead to seromas. And so we're so fearful of seromas in plastic surgery. From a deep perspective, since it's not a foreign body, I'm more thinking about wound healing, the tightness of their closure, things like that. So different rationales, but similar timelines.
Okay, perfect. Um, how does functional medicine help optimize outcomes after surgery, especially in breast cancer?
I think once again, it's thinking about the patients holistically. And when a patient has, if you think about a trajectory of a breast cancer patient, they get this life-altering diagnosis. For patients that have neoadjuvant chemo, studies have shown that up to 60% of patients will develop metabolic syndrome. So they might go into medical menopause. Their insulin sensitivity is dramatically changed. They're insulin resistant now. Their cholesterol is all elevated. So they have this really metabolically damaging situation. And then they go into surgery, and we just hope they heal. And so we're not preparing them for surgery and guiding them through chemotherapy. So I usually meet my patients if they're planning for reconstruction at the time of mastectomy, either at diagnosis or soon after diagnosis if they don't need chemo, or very early in their chemotherapy journey if they're starting chemo before the mastectomy. I really like when I can meet patients early because I talk to them about those things. I say, you have 10 weeks at least before your mastectomy. So these are the things you want to work on in the next 10 weeks. Prioritizing protein, keeping track of your weight. If if your weight is increasing, patients are always told don't lose weight during chemo. Patients always gain weight during chemo, and it's not healthy lean muscle mass. It's fatty tissue because of those metabolic changes. So looking at your diet, prioritizing protein, working with gentle movements. If you're nauseous and fatigued during chemo, if you can just get outside and walk around the block, that's been shown in studies to be safe, decrease sarcopenia, improve outcomes with chemotherapy. So it's just working with patients with where they are, getting a plan that they buy into and is feasible, but just emphasizing to them the importance of putting in that work ahead of time so that they have the best possible outcomes at the time of surgery.
Any supplements? You mentioned supplements before besides protein. Anything else that you advise them to take?
Yeah, I love supplements. I think that there's this big misconception, especially on social media. I see this all the time, where especially influencers who really don't understand supplementation will say, you don't need supplements because we have a healthy diet. And what they're referring to is just for a day-to-day basis,
Mhm.
if you have a healthy diet, you might get in the adequate macro and micronutrients you need to be healthy and well. But surgery is this huge catabolic experience.
Okay.
There's tons of protein breakdown, there's inflammation, there's this massive immune response. So this is not a day-to-day function. This is an extreme environment that's happening in your body. So yes, we do need to support it with targeted supplements. Things I like are protein, once again, to support that catabolism and give your body the healing amino acids it needs. I'm a big fan of probiotics because those have been shown to decrease infections in pretty much all surgeries. I like arginine and glutamine because those are amino acids that are depleted during times of stress like surgery. A lot of the vitamins like vitamin A, vitamin B, vitamin C, vitamin D. Vitamin E is a bleeding risk, so I don't recommend vitamin E. I like things like omega-3 fatty acids because those are going to help quell your inflammatory response after surgery. And then I also like bromelain, which is an enzyme from pineapples, which has been shown to decrease swelling and inflammation after surgery.
You just do like just the pineapple, just kind of like the fruit. or is any?
Yeah, that's another huge misconception that I see all over social media. So, bromelain, the enzyme, is actually mainly concentrated in the pineapple stem or leaves. So, if you're making a smoothie and you throw in the stem or munch on the stem like a corn on the cob, you can get enough bromelain, but you need about 500 milligrams a day, which is what the studies have shown. It's hard to get. So, I usually do just recommend 5 days of 500 milligrams after surgery. It's
Okay,
just safer. And then you know what the dose is.
okay, perfect. Um, how do you approach body image and emotional healing with your patients?
Oh, that's so hard. It's it's so challenging. And there's once again, there's so much harmful messaging to women on social media. And I've even heard doctors giving this harmful messaging to patients. Things like you had cancer, at least you get a boob job, or how was your tummy tuck when people were talking about, a DIP flap. And it's just so harmful. And then some of the comments that people have made in clinic to me are, I don't care if my breasts are painful. I just want them to be larger. I want large breasts to find a husband. I want, large breasts to save my marriage, which is failing. So people are coming into this breast surgery. And I think that they're confusing it with an augmentation.
Mhm.
And so an augmentation is we're leaving the native breasts behind. We're starting at an optimal aesthetic standpoint. We're using tiny little incisions versus a reconstruction. I think patients often forget we're starting with skin. We are literally starting with skin and we are trying to make something that resembles a breast. And you can do it through implants or body-based surgeries, but there's still certain limitations. There's a definitive scar burden, which cannot be avoided. There's going to be potential complications, which are at a higher rate than just a simple augmentation. You might need radiation, which is going to impact the aesthetics of the breast. So I really like my patients to bring in wish list photos, and that has been so eye-opening to me. Wish list photos either that they like or that they don't like, because both are helpful. And I have the patients point out on the photos what do they like, what don't they like. And what I found is that sometimes it's not the reconstruction on these photos, it's the patient's body habitus. So it'll be the same reconstruction on a thin woman and they like it, or on an obese woman and they don't. So it's pointing out those things and saying to the patient, like, well, your body habitus actually resembles this, and this is why. Here's what I would anticipate your results to look like. So I also show some of my own patients before and afters, and they're not my best cases, they're not my worst cases, but they all illustrate very specific points, whether it's positioning of implants, scar burden, what radiation does. But you can see when patients are looking at these photos, there's kind of an aha moment. It kind of clicks. Me describing what a scar looks like doesn't mean anything, but if they can see on another woman what a scar looks like, what radiation looks like, that's really important. And same thing when I have women who come in, I have a lot of revision cases. So have their reconstruction elsewhere, want to have some type of a revision. And so the first thing I have them do is describe what they don't like, even before I say what I notice. And once again, it's really eye-opening because I look and I think, oh, your implant's too narrow, your incisions are too low, all these things. And then they point out all they care about is their nipples are slightly off. So it's so important to really hammer down what's bothering them. And then the most important thing is getting women in counseling because this is such a deep-seated, challenging topic. And unless you talk to someone where you really embrace body confidence and what is a new normal for you in regards to aesthetics, even the best breast reconstruction is still not the same as their native breasts. There's no sensation for the most part. There's potential for complications. There's scars. So I am a huge fan of sending patients to counseling early and often.
Mhm. Yeah, that's very good. I don't think I have heard anybody talking about that. I think that's very powerful because,
Mhm.
like you're right, you're thinking about how you're gonna look or how you always wanted to look, and this is an opportunity for you to look that way, right? When insurance is covering, right?
Absolutely.
So many times it's like, oh, I'm gonna have a boob job and my insurance will
Yep.
cover, right? And it's
Yep.
like, oh my God, you're going to a disease for God's sake, right? You just need to
Yep.
but and then I don't know how the breast surgeons you work with. Our breast surgeon here So sometimes the woman wants to go to just go flat, so the closing is a little bit different for flat closing, right? So
Hmm.
sometimes,
Hmm.
so I sometimes I explain that to patients because they were like wanted to have reconstruction and then they change their mind and then they're upset because you have this extra tissue on the side. Like, well, you need to make your mind a little bit. And again, things can be solved later, but if you're not going to have reconstruction, you have to kind of like make those decisions a little bit ahead of the time. So.
Yeah, absolutely.
How do you work with other practitioners, oncologists, physical therapists, nutritionists, or to support a comprehensive recovery?
One of the benefits of being at an academic center is in a cancer center is that my clinic is in the same building as a lot of the other providers. So I am in the same facility as the radiation oncologists and the medical oncologists and the breast surgeons, and we have imaging. So that is the first thing that I really think encourages just an overall comprehensive, well-rounded approach to patient care. I think the other thing is that I'm just super blessed to have breast surgeons that I get along with like really well. We work well together, personalities click. And so we're just in constant communication with each other, talking about patients, what incision, what's the plan, is it delayed reconstruction, immediate reconstruction. And so I think that once again, I just lucked out that I have a great team of breast surgeons, medical oncologists, radiation oncologists. One of the challenges at being at a big medical center like Duke, though, is that I think that for patients, it can get very overwhelming and they can sometimes feel like they're getting lost in the cracks. So, a place like Duke does have opportunities for counseling and exercise, recommendations, physical therapy, sex therapy, but patients either are not aware of it, so that's challenging to make sure that patients are aware of all their options, or we even have so many facilities that maybe they're being treated in Raleigh, but the sex therapist is at Durham. And so that can get challenging to navigate too. So I think there's pros and cons of being in a large academic center. For the patients, we just have to make sure that they're aware of their options. We have a monthly newsletter that goes out that just lists the options for patients and a contact if they're interested in that. And then patients fill out surveys before clinic that kind of vaguely assess what their emotions are and how are you happy in your relationships, pain, things like that. So then if I see a patient flagging something as being challenging at this time point, I just make sure that I make that necessary referral, whether it's to some type of therapy or physical therapy, counseling, whatever they need in that moment.
Okay. If we kind of go a little bit into what are some of the misconceptions around breast implants or breast implant illness that you want to talk about?
Yeah, so I think breast implant illness is such a challenging topic. And as a plastic surgeon, as a doctor, I'm a huge fan of evidence-based medicine. So I try to make my recommendations to patients based on well-done studies. And if I make recommendations that aren't based on well-done studies, then I'm open with the fact that maybe this has been done in an animal study, but this is why I think it's translatable to your situation, whatever it may be. So for breast implant illness, for those listeners that don't know what that is, it's a disease where patients have systemic symptoms and they're often very vague, things like muscle aches, hair loss, fatigue, and they believe that it's coming from their implants.
Uh-huh.
And so it's a huge area of research right now. There's lots of prospective studies currently going on. But what we do know that has been published in our field is that there are women with implants, both saline and silicone, for reconstruction and for cosmetic purposes that believe that their symptoms are coming from their implants, have their implants out, and feel better. Some people feel better the next day. There's a second group of people that believe that their implants, once again, are causing those symptoms, have their implants out and feel better for a little bit, but then kind of go back into having those same symptoms. And then there's a third group of people who feel no different whatsoever. So it's impossible to tell when you have a patient who presents with these, once again, kind of vague symptoms that could be coming from many different disease states. Are they coming from her implants? It's hard to know which group she'll fall into. But what the studies definitively say is that it does not matter if you remove the capsule around the implant. So when your implant is placed in your body forms a scar tissue around it. That's called a capsule. We want that to form. That's what keeps your implant stable, not flopping all around in your body. So that's important. That's good. What people who exploit women will say is that you need to remove the capsule in entirety in order to resolution of your symptoms. It's called an en-bloc capsulectomy or a complete capsulectomy. Here's where it gets dicey. Depending on where your implant is placed, if your implant is below the muscle, the capsule is overlying the ribs. Underneath your ribs are your intercostal muscles and then your lungs. I've had to do complete capsulectomies before for ALCL, which is a blood cancer associated with implants, where the treatment is a complete capsulectomy. And those surgeries are hard. The capsule is adherent to the rib. You are scraping it off the rib. Very challenging. Not in my own practice, but have heard stories of patients needing chest tubes after the
Oh,
surgery.
wow.
So not a benign surgery. So it can be done. It's challenging, but it can be done. If the implant is above the muscle, it's a little bit easier because you have this nice interface of it's just on top of the muscle. So there's a nice safe barrier in between the implant, the capsule, and then underlying scary stuff. So these surgeons will tell women the only way you can have resolution of your symptoms is a complete capsulectomy. They will charge women $30,000+
Oh
to
my God.
have the implant in their capsule removed. They will also just happen to be selling supplements that are not evidence-based whatsoever that detox your body after implants. They also will happen to sell red light machines and all this other detox voodoo that they say these patients have to have, which is all out of pocket. None of this is covered by insurance.
Wow.
Or if it is, they just don't accept it. So it's really disappointing when you have these women who are so desperate to feel better from their symptoms. They have all of these aches and pains. They don't feel like themselves. And then they go to a surgeon who offers them a potential solution and is charging them an unethical amount of money and selling them completely unevidence-based things. I have seen in my own practice women where I removed the implants and they felt better after surgery. And I was happy to remove it, but I have that discussion with them before and after or before surgery where I say, this is what we know. This is still an evolving area of research, but right now the literature supports that you don't have to remove the whole capsule. And here is why I won't. I will if I can, but this is why I'm not going to go after those last little bits of capsule because it's not evidence-based and it's potentially dangerous. So that is a huge myth on social media. There are very vehemently outspoken people on social media propagating this complete capsulectomy. I will be very honest and say that is just what we know right now in the literature. Could it evolve in 5 or 10 years? Absolutely. But that is just what we know now, and that is what's safe for women.
Got you. Do you talk to them a little bit, their concerns about toxins or inflammation and a long-term implant safety as well, like all that correlation?
Absolutely. There is a huge risk discussion that we have about implants, and breast implant illness is one of those things. And I tell patients, I don't know if you're going to be one of those women that feels that way after surgery. There's no way for us to predict. From a toxin standpoint, obviously that's something that I learned a lot about in functional medicine and the impact of systemic inflammation or localized inflammation. So what we know in the literature is that when those studies looked at removing the capsule, not removing the capsule, they looked at everything from biofilms to molds to inflammation, and they weren't able to find any correlation between any of those potentially inciting factors in patients' symptoms or resolution of symptoms. All of the materials that are in silicone are well below safe limits, and it's an inert object. So I feel comfortable putting that into patients. But it does cause a little local inflammatory response. It has to create that capsule. So will we know in 5 or 10 years that maybe that's not healthy? Potentially, but we don't have any indications right now that it's any health negative impact. Other things to think about long-term risks of implants are things like that lymphoma I talked about. That has largely been associated with textured implants, which is why most people use smooth implants at this point. And then the most important thing is that implants aren't lifetime devices. Even if you have them for reconstruction, they do need to be replaced about every 8 to 12 years. Those surgeries are covered by insurance, but it's still an insurance, or excuse me, a surgery. It's still time off work and a copay. So it's super important to tell patients because you don't want to give them something that requires maintenance that they have no idea.
Yeah, yeah. Or they're expecting us for the rest of their life and they're
Exactly.
better. Yeah, yeah, that's a very good point. What are your thoughts about nipple, right? Sometimes I have a neat experience where, when I see them from the rehabilitation standpoint, it's kind of like they go back into your function, you're great. It's just a matter of just if you have to do any touch-ups with plastic surgery to make your breast more symmetrically. But we really don't see them like when they looking into either a nipple reconstruction or a nipple tattoo. Um, do you think is how important you think is that for a woman to kind of like close that up?
Yeah, we are lucky enough that we have a physician assistant who does 3D nipple areola tattoos that look amazing. And it's hard that, it really is an individual choice. And some patients don't care at all whether or not they have a nipple reconstruction. Some patients don't want a nipple reconstruction because they want to be able to wear a shirt without a bra. And if you have a nipple reconstruction, it's always kind of erect. So you do have to wear some type of bra if you want to hide that. A lot of patients want to avoid that. So then they either opt for a nipple areola tattoo or nothing. I think that having the nipple areola tattoo really lends a certain aesthetic, favorable outcome to the reconstruction. It just does something with your mind where it tricks it tricks your mind into thinking that the reconstruction is more 3D than it is, especially in women who have a skin sparing mastectomy or a horizontal scar across their breast. It hides the scar, it makes it look more projected, and that's often women's main concern with their reconstruction is that it's not projected in the same way that their breasts were projected. But it's such an individual choice if, whether or not it's important to them. It's really important for patients to know that even if they have a nipple reconstruction, it's still insensate. So it might look like a nipple, you might be able to run your fingers over it, but it's not going to react like a nipple and it's not going to have any sensation. But it's just such an individual choice as to whether or not it's important to patients.
Okay. Um, do you find resistance from traditional colleagues from incorporating functional medicine into their surgical care?
Oh yeah, absolutely. It's a constant battle. I would say that my main battle is with anesthesiologists, and it's because I recommend supplements to my patients, and I ideally want my patients to take supplements for 2 weeks before surgery and 2 weeks after surgery. And I did a lot of research to look at supplements that are evidence-based to help wound healing, either in human studies or in well-done animal studies. Safe, meaning that we don't know any risk of interfering with anesthesia, and most importantly, no increased bleeding risk. So I did a lot of research on this. Give the patients the handouts, they go to their pre-operative appointment, and their anesthesiologist says stop all supplements 2 weeks before surgery. And it's hard because we know how many supplements are out there. And so patients come in with this list of 15 supplements. It's really challenging for a doctor who's not familiar with supplements to go through and know what's safe, what's not. So I usually tell my patients, because then I get a message, you told me to start, my anesthesiologist, what should I do? So I tell them that, look, I researched it. I am your surgeon. I feel totally comfortable with you taking these up until the day of surgery. But if you don't want to, that's totally fine to start on the day after surgery. The main one that gets the most pushback is omega-3 fatty acids. I'm not sure where this started, but people thought that omega-3 fatty acids increase your bleeding risk. I think that it was shown in just cell culture that it increased bleeding times, but there have been meta-analyses looking at patients and omega-3s up to 8 or 9 grams, which is a tremendous dose,
Yeah.
showing that it doesn't increase bleeding risk, it doesn't increase transfusion risk, and it actually might be protective of blood loss in surgeries. So with that, I feel totally comfortable with my patients taking it. It's just a never-ending battle.
Yeah, but you have never come across somebody like bleeding more than usual for taking it either.
No.
So yeah, yeah. Maybe they just need to listen more, right? I think I think it's also nice to have a combination, right, of the traditional medicine and
Absolutely.
functional. I think that that's such a big piece that is missing now, and I think is more out there. It's just more people like you and just really talking more, people understanding more, feel like start taking care of themselves more. Um,
Yeah.
it's really making a difference now. Um, What are some things that you wish every breast cancer patient knew before undergoing reconstruction?
I wish that every patient knew that they could prepare for surgery. I think that when, like we talked about, when people are approaching surgery, what they're thinking about is who's driving me the morning of surgery, how long am I going to stay in the hospital for, and how long do I need to take off work? That's it. And then when patients show up the day of surgery, even if they're planning on staying after surgery, they don't bring anything with them. Versus, think about when someone's having a baby. They have their bag packed, they have the room ready, they are months ahead of having that baby. They are ready. It's the same thing. You can prepare your mind for surgery, you can prepare your body for surgery. You should prepare your home for surgery, your social networks. I had a patient come in today to clinic. She had a mastectomy last week with tissue expander placements, and it's really hot here in North Carolina. And she went out less than a week after surgery and started watering all of her plants on her farm. Felt a sensation in her breast, her drain started having increased output, the breast turned red. So it's those things that you're not thinking about. Who's going to water my flowers after surgery? Who's going to walk my 15-pound dog after surgery? It's all of those things that you need to think about before surgery so that you have less stress after surgery.
Is any tools, books that you recommend for women looking to take a more proactive role in their healing?
Yeah, there aren't. That's why I'm writing one. You know, there's a lot of wonderful books out there that are aimed at patients for navigating a breast cancer diagnosis. And they focus a lot on oncology. Should you have radiation? What's a genetic diagnosis? Should you be tested for BRCA? Things like that. Whereas my book that I'm writing is really focused on preparing for surgery. But when you think about it, and I think this is an often overlooked fact, we all know that the statistic now is 1 in 8 women will be diagnosed with breast cancer, which is a lot of women. Within those, 90% of people will have, 90% of women will have at least one surgery to treat their breast cancer. So it's like 1 in 9 women are going to be having surgery for breast cancer at some point in their lives. That is a lot of women. So none of us know when we're going to need surgery. None of us know when we're going to be diagnosed with cancer or in a trauma that would require surgery. So it's really just living your life with that in mind, as morbid as it sounds, but it's keeping your body healthy. It's always working on your muscle mass and your protein intake and trying to modulate stress and sleep. It's just healthy for overall life, but it's going to also help you if you're one of those 9 people that need surgery, or 1 in 9 people that need surgery.
Okay, I'm sorry. When is your book gonna be ready?
It's written. I'm in the search for an agent, so if anyone's listening and wants to publish a book. But
Okay.
yeah, it's frustrating because I started my social media page to have this information so readily accessible, but you go through Instagram and it's, 3-minute reels on vitamin C or omega-3s. And I really just wanted a resource that I could
Oh,
give to my patients,
that's
but there
great.
isn't one out there.
Yeah, well, I'll be looking after. I'll be
No, thanks.
working it as this out. You mentioned something on your, and this is for your wrap-up question. You mentioned something that you did some research or your interest was a lot of like neoadjuvant chemotherapy. So what would you advise women when they're going through neoadjuvant chemo to prepare better for
Yeah.
like mastectomy that is coming up or reconstruction?
Right. Most women, like we talked about during chemo, are told by their oncologist, just try not to lose weight. And that is seen with a lot of other cancers, like head and neck cancer, that's associated with a lot of weight loss. And it's important to keep your lean muscle mass and not lose a lot of weight. But most women going through neoadjuvant chemo are going to gain fat mass, lose lean muscle mass, develop insulin resistance. So if you have this neoadjuvant chemotherapy, one, it's doing what's possible and having some grace with yourself and being just mindful of what your body's going through. You're not going to feel like exercising every day. You're not going to feel like having chicken breast every day. And that's okay. It's doing your best every day and not being frustrated if you can't do exactly what you wanted to do that day. But even small incremental changes, Just if all you're able to do is walk up and down the stairs a couple times, or just go outside and walk for 5 minutes, that is so much better than doing nothing. And if you have no energy to do anything today and all you want to eat is cupcakes, just try again tomorrow. But it really is trying your best. And I see a lot of women, they have so much guilt with their diagnosis. It's what did I do wrong?
Yeah.
Why did I have this cancer diagnosis? I exercise, I eat healthy, I don't drink wine. Why me? What could I have done different? And then they also translate into chemo. I have no energy. I'm gaining weight. I don't like the way I look. So it's just forgiving yourself and just being mindful of everything your body is trying to do. And then just every day waking up to try to do the best you can, because it really is just going to help that long-term chemotherapy outcomes and surgical outcomes as well.
That's a very good advice. Well, that has been an amazing conversation, full of great information. Like I said before, looking forward for your book to be out there. Um, Thank you so much for your time. That was very valuable.
Thank you so much for having me.
Excellent. You have a great rest of your afternoon.
Thank you, you too.
Okay, bye.